Are we up and running?
We are now
Shall I
recording,
crack on?
so I've got great pleasure in introducing Dr. Jane Johnson. So hearty
Yeah.
congratulations. Since you last
Thank
presented for
you.
Jane, you've got your PhD, which is
I have.
tremendously exciting news. And Jane is going to be talking to us about assessing range of movement. And she's going to look at the three main approaches to assessing range of movement, what simple range of movement tests we can do, and then when someone says that they have a stiff joint, how do we know it's really stiff? Now, Jane is a chartered physiotherapist that specialises in occupational health. She's currently clinical team lead at PAM Physio Solutions. If anybody knows Jane, they'll know that she's passionate about sharing information and is the author of 7 books, including the best-selling Postural Assessment. And I understand that your PhD explored how to quantify human posture.
It did indeed. It took me a very long time, and I realised it was very difficult to quantify human posture when I got to the end of it, which I think what a lot of people find when they do a PhD.
Yeah,
What you start out morphs into something completely different.
absolutely.
Well, that was a lovely introduction. Thank you very much. Yes, I think you've had a lot of interest in assessing range of movement. This is going to be approximately an hour long. I do have a tendency to talk quite quickly because I get, like as Neil says, I get very excited. I'm really passionate about sharing information in a way that I hope is sort of easily digestible. And hopefully there'll be time at the end to ask questions if you want to ask me questions. I have got a cup of tea here. Hopefully that you've all got a cup of tea as well, or you've got a drink of some kind. And we're going to get cracking. I've just got over COVID, so I'm a bit snuffly. So occasionally if I go quiet, it's just because I've muted myself just so that I can cough or sneeze or something like that. But let's crack on. So what are we hoping to achieve by the end of the webinar? Well, there are lots of different ways that we can assess movement, and we could deliver this webinar in lots of different ways. It's a really big topic, but what I've done is I've sort of cherry picked some of the things that I found most helpful over the years and which I think might be most helpful to you in a practical sense. So as Neil says, we're hoping to state, why assessment and range of movements are used, what it can tell us, list the three sort of approaches to assessing range of movement. I'm going to give you lots of ways to demonstrate range of movement. So I'm going to give you lots of tests that you can do. And of course, identify if someone does say they've got stiffness, how do we really know that a joint is stiff? Now, what do they mean when they say stiffness? So let's get cracking with these. What I'm hoping is by the end of the webinar, you might be able to look at this picture of this person and you might be able to describe the positions or the ranges that they've been able to put their neck, their shoulders, their knees and their wrists in. What position has this person managed to get into by the end of the webinar? So you could come back to that and try and sort of test yourself. I have actually got at the end of the webinar, I've got a few little questions that you can test yourself on. And I've written them out in green, so I apologise if anyone doesn't like green. But what I've done is there are some prompts to those answers in green throughout these slides. So hopefully you'll pick up some ideas. I always find that when I attend a webinar, sometimes I might know quite a lot of it. I know we have got some physiotherapists joining today, and if you're listening as a physiotherapist or as a sports rehabilitator or something, you will certainly have had a lot of training in assessing range of movement, but I'm hoping that at least you'll pick up a tip or an idea, or it'll reinforce something that you think, oh yes, I remember that. That's a useful tip, or I should remember to do that. If you've never assessed range of movement, hopefully you'll go away with some skills and you'll think, I know how to do that. I can practice that on my partner or my family, a few friends, and maybe even test it out on a couple of the clients, some of the people that you're assessing for your work. It's quite practical. There is a little bit of a preamble to start with because I'm going to go through a little bit of the theory just to explain a little bit about the different ways we test range of movement or range of motion. You can use those words interchangeably, range of motion, range of movements. But of course, the best way to learn a practical skill is to actually do it. So today, if you want to practice while I'm talking, follow some of the illustrations, the images that I'm going to show you, then feel free to do that. If you don't want to practice, you don't want to move your wrists or your knees or your neck because you have an impairment or you've got some discomfort, that's absolutely fine. It's entirely up to you. So you're in charge of how much movement you do or don't do. You might just want to sit and listen. So what are the types of range of movement? Well, there are two main types. The first one is active range of movements, and we call it ARM for short because the acronym for range of movement is ROM. So if someone talks about a ROM test, we need to be clear, are they talking about an active ROM, an active range of movement, or are they talking about a passive range of movement? Does anyone know the difference between ARM and a PROM, active and passive? I don't know if you're on mute or if you can be unmuted. Normally we mute everyone so that we don't hear rustling sweet wrappers and popcorn and things like that.
I think one you do yourself and one you're assisted with. Is that
absolutely. Right? Yes, absolutely. Well done. That's absolutely right. I'm going to give you some pictures to show you that. There is another type of movement that I've slipped in here. And it's an accessory movement, and I'm going to describe an accessory movement because what I learned about accessory movements, I was really excited because some of my training before I became a physio didn't include accessory movements, and those are very important. So I am going to come back to those as well. I've highlighted what the webinar focuses on, which is active range of movement, and you'll see why we're going to focus on that. So here we've got a couple of examples. If you look at the top left-hand picture, this is a gentleman who's flexing his knee. He's bending his knee and he's bending his hip. So he's had a straight leg and then he's taken his heel to his bottom. If you look at the similar movement on the right-hand side, just as you've said, a passive range is when someone else does it for you. So a therapist has tried to bend the knee and bend the hip. If you look at the picture on the bottom left of the screen, there's someone face down. We call that position prone as opposed to supine. So when they're face down in the prone position, this person's also bent their knee. They flex their knee to about 90 degrees. And again, on the right, there's the associated passive range. And you can see that the therapist managed to move the joint through a little bit of a greater range of movement. They've managed to bend it a little bit more. And there are pros and cons of whether you do it active and passive. There are advantages and disadvantages of both, and they tell us different things. So, of course, if someone's moving the joint themselves, that's telling you a lot about their willingness to move the joints and how much strength they've got in their muscles to do that. Whereas if you do it passively, someone might appear to not be able to move a joint, but actually you could move it as a therapist. So there's no restriction in the joint. It's just that for either they don't have the muscle strength to do it, or the nerves going to those muscles, or they're simply unwilling to do it for whatever reason. But there is something very interesting that you need to always remember when you're testing, whether you're doing it actively or passively. If you look at the top picture on the left, the gentleman in supine on his back, and you look at the picture below that where he's in the prone position, he's face down. The prone position does not involve any movement of the hip, and that might be a good thing because you don't want any limitations in the hip to restrict your testing of a knee joint if you're just focusing on the knee. If you look at the top picture, he's had to bend his hip slightly in order to bend his knee when he's in that position. If you look at the bottom picture on the left, if he had a very tight, it's called a hip flexor muscle, like the quadriceps muscles or rectus femoris, which is a quadricep muscle, or a muscle group called iliopsoas in the hip. If they're very tight, running down the front of the thigh, he may not be able to flex his knee because it's restricted by the muscles. So by changing the positions of a person, you can help determine what's causing the restriction. Why is there a restriction there if there's a restriction at all? So the testing position is really important. And obviously, if you're testing someone and you're going to do an intervention, whether you're physically going to put your hands on them or you're going to give them some exercises or stretches, and you're going to test them again, maybe after that treatment or a couple of weeks' time or whatever it is, you've got to remember what position they're in. So you need to document what was your assessment position. This is something I've just slipped in because there's a kind of a mid-range assessment. It's called active assisted. So let's say this gentleman had very stiff ankles and he couldn't dorsiflex, so he couldn't actively pull his toes towards him. Let's say he'd had a drop foot, he'd had some sort of injury to his shin. Very commonly, if someone takes part in martial arts, for example, a particular nasty technique is to kick someone on the side of the leg because it temporarily immobilizes the ability to dorsiflex, to pull your toes up. And so that's a very specific martial art technique. But of course, following fractures, you can damage the nerve as well. And you might want them to be able to dorsiflex. And so what you're going to do is you're going to give them a towel and you're going to give them an active assistive range of movement because they can't physically themselves dorsiflex their foot. And of course, it's going to stretch the calf muscle on the back of the leg and the Achilles. So it might be used for that reason. But just to let you know, there is that sort of also that area which kind of active, but they're doing it with some form of a system. It doesn't have to be a towel. It could be a rope or a band or a bar or something. So what is this accessory movement? What's that? Accessory movements are really, really interesting. Before we go through this picture, if you take your left palm and you keep it flat, and you take your right fist and you put your right fist into your left palm at a 90-degree angle, and you very gently, almost not fully, cup your left wrist slightly. What you've made is you've made something that represents the glenohumeral joint, the shoulder joint. And then if you move your right arm, your right fist up and down as if you're moving it in the joint, you can see that your knuckles change position, don't they, against the palm of your hand. So your knuckles are changing their position as you're moving up and down. And what happens is with the shoulder joint, in order for us to be able to take our arm out to the side and higher up, the knuckles, if you imagine it, or the top part of your humerus bone, it has to sort of move up and down. It has to glide up and down. And that's called an accessory movement. So accessory movements are those which occur as part of a normal movement. But the interesting thing about them is a person cannot bring about just the accessory movement on its own. And you might be thinking, oh, Jane, well, why on earth is that important? Why do we care about accessory movements? Well, accessory movements are important because when they stop working, the overall movement doesn't work. So typically, if someone had a frozen shoulder, the whole joint gets gunked up. And one of the ways we can ungunk it, we can unstick it, and we can facilitate movement is to facilitate the accessory movement. So why have I got these tube trains on the screen? Well, if you look at these tube trains, there are lots of carriages joined together. And if you think about this, the driver at the front, when they are driving the tube train, all of the carriages follow. They can't choose to only pull one of the carriages as they're going around bends and curves and curves in the track. All of that train comes with them. And if ever you've seen any mechanics at work, you're working with mechanics, with the transport industry, they may go in and they may uncouple some of the train and they might all, clean out and degrease it and do different things because it's all sticking and not working quite right, and then put it back together and then it carries on. Well, if you look at the spine, this picture on the right, I don't know if you can see my cursor, but they're called apophyseal joints, little tiny joints here. This is a side view of a spine. And these need to move along with the spine, the whole spine. Now, while you're sitting, if you turn your whole body to the right, so you do a little rotation and then you come back, and then you turn your whole body to the left and you come back, as you've done that, these bones all down the middle have moved, but so have these little apophyseal joints. And sometimes when you can't rotate, it's because some of these have got stuck. So a therapist can go in and they can actually assess the stiffness of an individual joint. So they will test the accessory movement of that joint. And normally, if they mobilize it and they move it around, and then they ask you, okay, can you turn to the right again? Can you turn to the left again? You'll actually have a greater degree of movement. But you yourself would not have been able to unstick that individual joint. Now, I know some of you might say, oh, if you're therapists, certainly if there's any physios, or other clinicians listening, like chiropractors or osteopaths, you might think, oh, well, no, you can actually do that. There are some tricks, and you might find them on YouTube where you can do that. But generally, people can't do that individually themselves. Another example of an accessory movement is if you think about your wrist joint. Your wrist joint, and I'm going to show you all the different movements of the wrist and how to test it, but you can distract it and then you can compress it. So you can pull it apart and then you can compress it back together. So you can sort of do that accessory movement yourself, and that would occur as part of some of normal movements. But just to bear in mind that there is this unusual type of movement called accessory movement as well. So why do we assess range of movement? Just a really quick bit of the theory. It helps us to determine if there's a limitation in the joint. It helps us to identify different musculoskeletal conditions. And it helps us determine function. So when it helps us to decide, we can form an opinion as to whether an employee may be able to perform a certain task or not. So if we know about that person's function, we can advise an employer as to what they can and can't do. So knowing if they can move a joint is going to be very helpful. And I can't think of very many jobs where people haven't got to move. There are some people who have obviously movement problems and movement issues, but they still almost, they have to move some part of themselves. Now, I'm just going to give you a quick example before we come onto the very specific joints. If you think about frozen shoulder, what do we call, what's the posh word for a frozen shoulder? What do we call it? Does anyone know? It's called adhesive capsulitis, and that's because adhesive is a gunky gluey substance, isn't it? Like adhesive you might buy in the shops, and something in the joint capsule, the glenohumeral joint itself, gets all stuck up and gunked together. And in this condition, a movement called external rotation is commonly lost. So what that means is, if we're assessing someone for a shoulder condition and we're trying to work out what it is, and we discover that they have lost external rotation, then one of the conditions we might be thinking about is frozen shoulder. So what is external rotation? Just because I've mentioned it, if you see that picture on the top right of the screen, if you imagine you're pulling something really stretchy, like some piece of, I don't know, pizza dough or some stretchy TheraBand or something, and you've got your elbows in at your sides and you're pulling this apart, but you're keeping your elbows in, that's external rotation at the shoulder. And when someone's got a frozen shoulder, or if they've had one and they've come out of that condition now, it's very interesting, because if you ask them to do that movement, very often there's a limitation in range. So the shoulder that was frozen, they can't do that movement. So that's a lovely, very, very simple test. And it's a sort of test that those of you that are treating people remotely, you could actually do that telephonically. You could possibly observe them on video, but you could even ask them, if you were trying to pull a piece of dough apart, what position would your shoulders be in? Can you do, for example, a big clap with your hands? If you were going to clap your hands, but you had to keep your elbows in at the side, can you take them apart before you do the clap? Is one side restricted and the other side more free? And there isn't a big range in that particular movement, but it will give you an example about restriction. And I'm going to come on to this more specifically. So one of the questions I suppose I've always got in the back of my mind is, should we focus on assessing a specific range of movement? And I'm going to come up back to these shoulder pictures. These are examples of specific ranges of movement. So for example, you can see in that top left hand picture, could you take your arm behind you? If you look at the bottom right hand picture, could you take the arm out to the side and then in front of the body? These are examples of specific ranges of motion. How useful might they be to you? And it might be that they're very important because there's a very specific position the person has to put their body in, and so you're going to need to know specifically what degree of movement are they going to do. Specific ranges of movement are commonly used following injuries and commonly used following joint replacement. So for example, some surgeons will not discharge someone unless their knee range of movement can be measured to a certain range. And so there is a very specific criteria. And the reason that's put in place is because we know that they need that sort of range in order to sit down on the toilet. And if you haven't got that range, you can't sit down on a toilet, a basic human function, something like that. And there are lots of different ways that you can test this, but you have to ask yourself, do we need to be specific? There's a couple of books here I just want to show you. They're actually the same book. The first one was published when I was born, 1965, and measuring joint motion, measuring method of measuring and recording, and then it was republished. And it's a slightly bigger version. And the one on the left is my favourite. And I don't know why, but I don't know if you ever had this experience. Sometimes a republished book isn't always better than the original. It kind of looks a bit bells and whistlesy, if you know what I mean. It's all sort of sizzle and no substance. Now, I don't mean that about this particular title, because the book on the right is a very good book, but there is something that aesthetically really appeals to me about the one on the left, because when you open it, it's got these really sort of 1960s, 1950s hand-drawn black and white pen and ink illustrations, and they've all kind of been cleaned up, and they're all really great illustrations in the book on the right, but there's something very clinical and very stark about them. Whereas the one on the left, you know, I just think they're sort of, I don't know, they're gentler and they're quite nice. But they've obviously added more information to the one on the right. The one on the left was actually very expensive. It's $100, and it's actually the size of your palm. And I had to learn it inside out when I was a physio all those years ago. But if you're interested in very specific measurements, those are quite useful books. So this is sort of following on from the previous question: should we measure specifically, or should we consider just overall function? So here's a question to be mulling over. For example, if someone can't fully bend their knee, but they can go up and down stairs, are they fit for work that involves stairs? Now, that's interesting, isn't it? Because there's lots of things we don't know, lots of answers we haven't got. What type of stairs are they going up and down? Like that gentleman there, he looks like he's on some stone stairs that could be in a beautiful villa in Madeira, which might be very nice to have as a second home. And he might have had I don't know, maybe he's got a prosthetic leg, you know, and he's quite fine going up and down his stairs in Madeira. Nothing wrong with that. They're safe. He's got a handrail. He's done it for many years. He's had this, you know, condition for many years since he was an amputee or something, and he's perfectly safe. But of course, that's completely different, isn't it, to someone whose job involves using stairs or even carrying something up and down stairs. But the reason I've put this in here, this little image, is because just because someone doesn't have a full range of motion doesn't mean that they can't do their job. We often think about, certainly in physiotherapy, what are the limitations? And does that limitation mean that that person can't do that job, either temporarily or permanently? And so that's something that I've always got in the back of my mind, is actually, even if they've got a limitation, can they still do that job? And if you're working with people in warehouses, as I've done a lot, and some of you will definitely have been working in that capacity, you will have come across people who've been in the same role for many years. They've had hip surgery, they've had knee replacement surgery, or they've got osteoarthritis, and they can't fully bend their hip, they can't fully bend their knee, but they've actually figured out a slightly alternative approach, and it's not entirely in line with the way we're taught health and safety, but it is safe, and they've learned how to do it in a way that works for them. You know, and they have been doing that job for many years like that, and it's not caused them any problems. So again, you know, always bearing that in mind. Now, I've just put this as a little aid memoir to myself. There's an X-ray on the next page, so there's nothing gory about it. It is a severe break in a bone that I want to show you, because I want to tell you a story about it. But if you don't like X-rays, then just listen for a minute. So this is a picture, and I'm just going to orientate you to what you're looking at. Imagine you're facing someone and you're looking at them. This is their right shoulder and their right arm. So this is a shoulder joint, and this is an elbow joint. It's a view taken from the front. It's what's called an anterior-posterior image. And you could, this bone here is the humerus, and it should be straight. It should go all the way up here to the shoulder, and there's a great big break in it here. And I know about this because my mum gave me permission to show you this, because this is her arm. Because in November last year, a year ago, she broke her arm. And this is what it looks like, and this is what it still looks like, except it's all now completely consolidated. This is all healed, but it healed like this. This isn't the healed image. The orthopedic consultant didn't want to operate, and I was really concerned about him not operating, but he felt that at her age, and she doesn't mind me telling you, she's 88, at her age, with osteoporosis, advanced osteoporosis, he felt that the risks of surgery would outweigh just leaving it like that. Now, why am I showing you this? I'm showing it to you because it has healed, and the consequence is that she can't raise her arms above her head. She can't raise this arm above her head. Now, if this was someone working in a factory, that may be significant because they may need to put something on a shelf slightly overhead. It could be a light item or something. They just have to pop there. Well, hopefully no one's lifting very heavy items above their head. But the reason it's affected my mother is that she's got long hair. She's had long hair all her life, and she prides herself in living independently, and she can't tie her hair up. She can't tie the clip on the back of her head, and she's trying to use her left arm, and she's really struggling, and it's really upset her. So it's had an enormous impact on her quality of life. And she was discharged from physio because they took one look at the x-rays and said, yeah, now the bone is healed. Obviously they were looking at the healed version. And said, there's nothing more we can do for you. You're never going to get your arm above your head. But my mother is from Sunderland, where I live now, the north of England, and she grew up not being able to afford. When she grew up, we didn't have the NHS, and they couldn't afford a doctor. You had to pay for doctors. And it was very much where you just, fresh air, cup of tea, and lots of exercise, and you'll be fine. And that's probably why I became a physio, because she just grew up with that ethic that, well, you just have to treat yourself. And so every day she raises her arm up, and every day she tries to do it. And it's really interesting. So when I've been to visit her quite often, she is improving. And I don't know whether she will ever be able to raise her arm above her head, because she'll probably have an awful lot of soft tissue contracture underneath her arm, because she had to keep it by her side for a very long time. So that's just to show you that for her, that had a really big impact on her. And so we always have to ask people, what do they have to do with that joint, that part of their body, both at home and obviously for us in occupational health? What do they have to do with it at work? Are they going to be able to, go back to work with an arm that they can't, lift over their head, and which they may never lift, over their head? So I'm going to focus the second half of this sort of webinar just about active range of movement. And why am I going to do that? Well, just to remind yourself, active range is when the person does it themselves, and a passive range is when someone does it for you. So here's a lady leaning her head to the right. She's doing it actively. And the image on the far right, this is a therapist who's about to take the head into lateral flexion, taking the ear to the shoulder, or maybe rotating it. So rotating the head to one side. And I always start with active range of motion, because do you have to move on to a passive range of motion? And the answer is, if you want to know if a joint is really stiff. And this was one of the selling points of the webinar. How do we know if a joint is really stiff? Stiffness is a subjective term, isn't it? And it's like soreness. How do we know if a joint is really sore? It's because that's what somebody tells you. So if a joint is stiff's a subjective term, and if they perceive it to be stiff, then you could document it as stiffness, because we need, as we know, it's really important that we use the terms with people that they use, because we want to gain rapport, and we know that they can help us understand that person's, potential yellow flags. How are they feeling about their condition? If we want to know if there is actually a restriction in the joint, what we might perceive as a stiffness in the joint itself, then we would do a passive range of motion, and then we would start to do those. The example I showed you earlier, where we might move an apophyseal joint, where we might actually go into the vertebrae, into the spinal bones, and we'd individually move one bone against another to determine how stiff does that feel, one joint against another joint in the spine. If we wanted to know, assess a frozen shoulder, rotator cuff, adhesive capsulitis, a person might say, my shoulder feels really stiff, and they might appear to not be able to move their arm out to the side or in different ranges. We would then assess that and say, can we move it out to the side and in different ranges? Because if it really is a stiff shoulder, frozen shoulder, we won't be able to move it either, because the joint itself is adhered, adhesive capsulitis. And we would go in and we would do a glide of the shoulder joint. So we would very gently put our hand on the front of the shoulder while the person's maybe lying on their back, and we would try and push the head of the humerus backwards in the socket of the joint. We'd physically try to move it backwards and assess how much glide is there. And again, accessory movements are also used. So if someone was you did that and you thought, oh my goodness, there's a lot of movement here, that might indicate there's hypermobility. That person's got extra movement. But very generally, I'm going to show you, active ranges of movement. They're all very, very safe. So what are we testing with an active range of movement? Well, we're testing what movement's available in the joint, the strength of the muscles to actually move the joint. And then that's why it's very important to think about the position in which you test someone. So think about this. If you're sitting, listening to this video, maybe you're lying this webinar, maybe you're lying on your back, I don't know, after a hard day's work. If you're sitting, listening to the video, and you try and take your arm out to the side, you abduct your shoulder, you lift your arm out to the side, you're having to lift your shoulder against gravity. Now, if you lie on your back on the floor, and if you want on a slippy surface, or if you're going to make snow angels or sand angels the way children do in the, maybe on the beach or in the summer, that's different. You might find that's a bit easier because you're not lifting your arm against gravity and you can still abduct it. That movement's called abduction. So taking gravity out of the equation can be very helpful to determine whether there is a problem in the joint or whether there's weakness in the muscles. So hopefully that's just to bear that in mind. So we test joints usually in lots of different positions. And also when we're testing active range of movement, we're understanding the willingness of an employee to move that joint. How willing is that person to move it? If we ask, can you do this? Can you do that? So let's now think about some very specific ranges. And again, you could do these, but you don't have to if you don't want to. If you look at the lady, excuse me, on the left, she's just standing in a relatively posture that you might see a lot of people standing in. And one of the ranges is called extension. And you could take your head backwards and look up to the ceiling like that. So you could ask someone, can you take your neck and shoulder, your neck backwards, and so that your face is facing the ceiling. And a lot of people will be very resistant to doing this if they've got a neck problem, because they'll say, no, that's going to aggravate my symptoms, I'm not going to do that. And when I was many years ago, I was a fitness instructor, and we were never allowed to do that with people. They said, no, you mustn't do that. That's actually terrible to do. You're going to damage their neck. There's no evidence to show that taking your neck back will damage your neck. And in fact, there is more strain on the upper cervical vertebrae, the C1 and C2 they're called, cervical 1 and cervical 2. When someone actually does flexion, it actually puts more pressure doing flexion. But just doing flexion like this without any pressure on the top of it is perfectly safe, and it would only be, if you were to put the hands on the back of your head and to do a little bit of a neck stretch, you're stretching the back of your neck here, it would probably only be injurious. If someone had very severe advanced osteoarthritis, or obviously you wouldn't be doing this if they had an acute injury. You thought, my God, they fractured their neck. But so taking your chin to your chest is not a problem, and we call it flexion. And you could see, what's the range someone's able to do. Lateral neck flexion, just taking the ear to the shoulder. You might have noticed, if you've ever done any tests, that very commonly, if there's a restriction, what do people do? They simply, well, try it yourself. Take your ear to your shoulder, take the ear to the other shoulder. Commonly, people might try and elevate their shoulder, raise the shoulder, taking the shoulder to the ear. So what we want to do is give them an instruction to say, keeping your shoulders down, keeping them still, can you take your right shoulder ear to your right shoulder? And then come to the center. Can you take your left ear to your left shoulder? Like this. And of course, looking over rotation, you might just simply ask someone, keeping your chest still, your shoulders still, facing forward or facing me, can you look over your right shoulder? And then can you look over your left shoulder? And I'm going to come on and expand on this. So what are we looking for when we're testing range of movement? And this isn't just to do with the neck, this is any joint. So bear this in mind as we go through the other joints. We're looking for restrictions in range, obviously. How far can they look over their shoulder, for example? Could they look over just a few degrees? Can they look right over their shoulder? Do they look like, they can look all the way over without any restriction? You might be comparing left and right sides. Can you look over the left side as far as the right side? Can you bend the left knee as much as the right knee? That kind of thing. So you're looking for a restriction in range and usually comparing left and right sides. You're looking for a poverty of movement. Now, what do we mean by a poverty of movement? I'll give you an example. Someone might say, they might do a movement, but it's juddery or restricted, and it does not a fluid movement. So they might do it by degrees, and it commonly happens in the neck or shoulder. They might do it slowly, 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 and that's because it's painful, or they're frightened of it being painful, and it's called a poverty of movement. So they can actually get through a full range. So for example, you might be able to rotate your head all the way to the left, but actually they've had to do it in degrees because they've been very cautious about it. So this is just a little tip again. If you were thinking, for example, about neck range of motion, and someone appears not to be able to look over their shoulder, or they don't want to look over their shoulder, and you want to maybe give them that as maybe that's one of the little exercises you want them to do. You want to increase range of motion, and we'll talk about why you might want to do that with the neck. Instead of doing it sitting, they could do it lying down. So tonight when you're in bed, if you take your pillow away and you lie on your back, and see what's it like to just rotate your head to the left and rotate to the right. It's a lot easier because you're not holding the weight of your head. So another little trick is we often give people exercises to do in the easiest position first, because obviously heads are very heavy, they can weigh up to a stone. But poverty of movement is something we look at. How good at the movement are they at doing it? And of course, things like wincing. It doesn't have to be the neck. Now, this lady here, she's kind of got a slight frown. You know, she's looking to her left. Maybe she's okay with that. But maybe, you know, if you were testing their range of wrist movement or their knee movement, or you're asking them to move their hip or their back, it's really important to be able to see their face. You know, are they in pain, or do they start wincing before they even move? You know, have they got any yellow flags there? You know, is there a potential barrier because they're frightened? You know, and they said, oh well, I did this once before and it really hurts. You know, so that's going to be a potential barrier, isn't it? I've just popped this little slide in because I want to tell you about this. I learned this trick years and years ago, and I've used it lots. This is a demonstration of how muscles restrict movement. And now I'm not going to do it during the webinar, but it's something you can practice with a colleague or maybe, you know, a partner or a family friend. If, for example, you're just working with a friend of yours or a family member, and you want to check their range of motion in the neck, what you can do is you can stand in front of them and you can say, okay, could you take your chin to your chest? Lovely. And now can you take your head up to the ceiling, look back up to the ceiling and look at that? Can you look over your right shoulder? And could you look over your left shoulder and then come forward? Could you take your right ear to your right shoulder and your left ear to your left shoulder and look at what they're doing? And we're going to talk about measurements because you can measure this as well, but I'm going to come on to that. Just look at what they're doing. And you might hear that they often use same words like, oh, it's sort of pulling or catching, or I can't, something's, you know, stopping me do it. And typically that's going to be in what we call lateral flexion. So they're not going to be able to get their right ear to their right shoulder if they've got stiff muscles on the left side. You know, their left upper trapezius muscles, or the levator scapulae muscle it's called, are very stiff and tight because those muscles restrict the movement. And you can, and they also restrict rotation, and sometimes the scalings do on the front of the neck. But you can test this for yourself, because if you stand behind the person and you passively, so this is an example of a passive movement, you elevate their shoulders. So you lift up their shoulders and make sure they're nice and relaxed. So you're holding their shoulders and say, okay, give me the weight of your arms. Let me hold your shoulders. And then you get them to do the movements again. What you'll notice is very often there's a freer range of movement. And that simply demonstrates that if there's a freer range of movement, it demonstrates that the muscles were restricting them, because by elevating the shoulders, what have you done? You have passively shortened, you've passively loosened the muscles at the top of the shoulder. You've made it all nice and loose, and you can test this. So as you know, if you've got your arms down, resting down, and you palpate up here, you poke about in the top of your neck and shoulder, it's a bit tight and firm. But if you passively rest your arm on lots of pillows, you can bank them up, maybe later on after the webinar, on lots of pillows, you passively bank your arm up, and then you press around in here, you'll feel that these muscles are nice and loose. So this is just a demonstration that tension in muscles can restrict joints. And so that's one of the reasons how we increase range of movement, is by giving people stretching movements to stretch the muscles, or suggesting things like soft tissue release, or massage, or trigger point release, or use of something warm that might give some pliability to the muscles, or something like that, because it will increase range of motion. So what do you do if you want to test these objectively? So for example, If you want to test a range of motion, the degree of range through which a person can move, there are lots of ways to do it. And these devices on the left are examples of goniometers. They come in all different shapes and sizes. And the book that I showed you earlier, the Assessing Range of Motion, it shows you where you put the goniometer and how you measure it. But again, you've got to come back to the question all the time is, do you need to know the specific number of degrees, or is it enough to know whether that's affecting that person at work? And the reason I put a forklift truck driver here is you may know, if like me, you've worked a lot with forklift truck drivers, forklift trucks are left-hand drive. I don't know why, but they are. So if I invented and patented a right-hand forklift truck, I would never have to work ever again, because I'd be very, very wealthy. And obviously they look over the shoulder when they're reversing the forklift truck, and that's very important. And if you assess forklift truck drivers, you will notice something very interesting, that they always have a restriction in certain ranges of movement in the neck. And you have to ask yourself, is that because they have been doing certain movements over and over and over again, like looking over their shoulder and the same shoulder repeatedly? And sooner or later, they start to have all kinds of problems. And in that job, obviously, you can't easily say, okay, well, don't look over that shoulder, don't reverse that way, don't use your left arm. There are only so many modifications you can put in place, and of course safety is a paramount, isn't it? Lots of safety issues involved. So there are lots of tips and tricks and ways you can measure range of movement. You can use tape measures and all sorts, but just bear in mind, do you really need that number? Why do you need that number? Or is it better to maybe keep a diary? So if you were working with someone and you wanted to increase the range of movement in the neck, you could say to them, for example, okay, so in the same position every day, sit in the same position, maybe with your back to the TV or something like that, look over your left shoulder. What can you see out of the corner of your left eye? Or I can see a bit of my plant. I can't see the television. I can just see a bit of the window frame. Okay, do these exercises, have these treatments, and a couple of weeks' time or 10 days' time, oh, I can see the corner of the TV. I can see my cat licking his full paws. I can see my husband stealing something out of the fridge. You know, whatever. What can I see? And they might have a greater range of motion. So what's practical? What's going to be really important? The shoulders, again, it's a practical way is, for example, you might just say to someone, stand by a light switch. Can you now take your arm out to the side and turn the light switch on and off? If you had your you were at 90 degrees, if you faced the light switch, can you now raise your arm to about 90 degrees, or to where the light switch is? It might be above them, it might be below them, depends on their body height, doesn't say it, where the light switch is. How far can they raise their arm up like that? So what practical tests, certainly if you're working with people remotely, could you use to help assess that range of motion? What's going to be important? Just windmilling the arms, taking the arms all the way round in a windmill motion, will give you a general idea about range of motion. And quite often people will do that as a test themselves. But when we're trying to get people back to work, sometimes we actually need to be specific about what range they can and can't do. So just being able to do a windmill motion or part of it, you have to ask yourself, you know, how helpful is that going to be? Okay, so let's crack on. Let's think about the low back. This picture on the left is I don't like to use the word neutral because they're all different, but the one on the left, the image on the left, is a picture of the pelvis from the left, kind of a neutral pelvis. There has been a lot of debate about, do we even have a neutral pelvis? It's very difficult to assess human posture. That, you know, as Neil said, I spent a lot of my PhD looking at. And the problem is we're all so diverse that we don't actually know what's normal. You know, I don't really like that word normal. What's normal for the person? The picture in the middle is an anterior pelvic tilt, and you could all do an anterior pelvic tilt now if you wanted to. You're going to change the position of your low back, and it will actually change your hip position. But while you're sitting, if you're sitting, try and sort of stick your bottom out. And if you're trying to stick your bottom out, what you've done is you've increased the curve of your low back. You've gone into a little bit of extension, it's called. And a lot of people don't like that when they've got back pain, because it squashes up the vertebrae on the back, the soft tissues on your back. This picture on the right, if you now try and do the opposite movement, you try and contract your stomach muscles as if you're going to, I don't know, you're going to imagine you're going to stop yourself getting punched in the stomach. Oh, I'm going to brace my stomach, and you're going to really, really brace. You're kind of flattening your low back. You've gone into flexion of the lumbar spine. You're flexing your lumbar spine. Sometimes you can suggest people try and press their low back into the back of the chair. That sometimes works. But things like contracting the buttock muscles and trying to stop a sucker punch into your stomach, that's a way of testing flexion of the low back in a sitting position. And these movements are great to practice because they mobilize your low back. So these ranges of movement, we use them as a range of movement test, but we also want to use them sometimes as treatments. I could do a whole webinar about treatment. I mean, hey, you can see already. I talk too much anyway, don't I? So those are just some examples of lumbar flexion. People very often sit in lumbar flexion. And obviously the back does lots of different movements, and we don't want any one movement. So if they can sit in these positions, then you know they can flex their lumbar spine because these involve lumbar flexion. And I'm not really covering hip flexion in this presentation, but this is also hip flexion and knee flexion. And again, I did a driving assessment yesterday, and we have to obviously check people's hip and knee flexion, and it can be one of the problems that causes back pain in drivers by having to constantly flex their hips. This is quite an interesting little thing I thought I'd throw in. I can't help myself. This is lateral hip hitching. It's quite a difficult assessment to describe to people, but I put this little picture in because it's a lovely thing you can do in the bath. I love taking baths. I'm not really a shower person. I know the world is divided 50-50 into baths and showers, but if you've got a bath, what you can do is if you're sitting in the bath, try and make one leg go longer than the other by trying to stretch out your leg to touch the tap on the bottom of the bath, and then or conversely pull up your hip as if you're trying to suck it into your hip joint. It's called hip hitching or lateral flexion, and it will involve lateral flexion. A simple way to test it in sitting is just for you to lean over. So while you're listening to me, if you lean over to one side and then you lean over the side, that's also lateral flexion. The difference is that your hip's in a slightly different position. What on earth is this when it's at home? Well, these pictures here, curving your spine to one side or the other, that's lateral flexion. And again, pretty much everything we do involves movement of the lumbar spine. And it's why when someone's got a low back condition, we try and get all of the ranges of movement back. Because it affects everything we do. You can't really say, oh, I can't do this movement, but I can do all the others, because you need the spine to move in all ranges in order to be able to walk. So what's this lady doing on her hands and knees? Well, here's a little trick thing you can do. You might not want to do it while you're listening, but maybe in the comfort of your own home. If you go on your hands and knees and you crawl like a baby, this is actually, your hip has to go into flexion and your knees in flexion, obviously, but your spine has to go into lateral flexion when you do this. You might not realize that. And it's a really good test because you're not weight bearing through your spine. So if you're standing upright, all of your torso is pushing down through the lumbar spine, but when you're in this position, it's not. So I actually often give this to someone to do to improve lateral flexion. And I get them to crawl about. And actually, if you crawl in a circle one way and then the other, that's even better because it mobilizes. It's called mobilizing your spine. It increases the range of movement. Why might we test spinal rotation in sitting instead of standing? Well, we're testing it in sitting often. And again, this does test the thorax as well. Obviously, we can't easily separate the lumbar spine from the thorax because the spine is a whole collection of vertebrae, isn't it? All on like a lovely long cord, like a cord of beads, all in one lovely direction. One lovely string. But we test it like this because when you're sitting down, your pelvis is fixed. So if you try and rotate now and you're not in a rotation chair like I am, you're sitting on a firm seat like a dining room chair or a chair with some other type of firm seat, maybe your sofa. If you try and rotate, if there's a limitation in your thorax and in your lumbar spine, it will be apparent because your pelvis is fixed. If you stand up and try it, you can cheat. Because what happens when we stand up? We just move the whole body, and often people say, yes, Jane, I can do that range of motion. So if you've got to test people's back range of motion as part of your job, I recommend that you do it sitting down. They get them sitting down because they can just cheat and say, yeah, I've got a really good range. And they're just, if you look at their hips, they're moving the whole pelvis. But again, let's come back to function. Does it matter if they have to move their whole body to turn around? Does that matter? Because we actually would probably do that. when we're moving around, if we've got a knee problem, and as you know, with those of you that do manual handling, when we're turning round, we don't want to keep our knees straight. We want to move our legs. We don't want to keep the pelvis straight and just move the torso or something, because we might damage our knees. We sort of want to move around. So, we could assess this range, but how practical is it in a real sense? It's quite good to show people whether they're improving, but from a functional point of view, you do have to ask yourself how relevant it is. You could test the lumbar rotation in supine, so you could get someone to lie on their back. It's actually very difficult to get your knees all the way over to one side, like this illustration shows. We use this commonly as a nice treatment to mobilize. We might say to them, okay, don't expect to get your legs all the way over, but just do a little bit, just rock yourself side to side. It's a really lovely way to mobilize it. You're sort of massaging the low back against the floor, your carpet or your bed a little bit. And if someone can do this entire range, then you would probably need to ask, are they hypermobile? Now, I've just popped this in here. Elbows, most people make a mistake of only doing 2 elbow movements. They'll test flexion, which is this person here, bending the elbow, or extension, straightening the elbow. But I said see wrist, because the elbow does a very, very important 2 other movements that most people fail to test. So we're going to come on to that. If your job was, I'm the company photographer, I get paid thousands of pounds and I've broken my elbow, obviously you've got to test their range, because they may be doing this kind of movement, and it might be very important that they can bring their shoulder all the way up here, because maybe they're on location, they don't necessarily use a tripod, I don't know, but you know that most of the jobs people we assess, people have to bend their elbows. A little tip here is when you're assessing elbow extension, check for hypermobility. It's one of the quickest ways to check if someone has extra mobility in their joint. Extra mobility in the joint will become apparent when they can extend the elbow, they can straighten it to a greater degree. When I was a girl at school, it was called being a bendy bunny. We didn't know what hypermobility was, and I had some girls in my class who would deliberately dislocate their shoulders or hyperextend their elbows, and God forbid, I don't goodness knows what they're like now, because that's not a good thing to be doing. When you have hypermobility, it's great because those people are more mobile. They're very good yoga teachers. They're fantastic at getting into small spaces, but they have much decreased joint stability. So in these people, obviously, we do not want to increase their range of motion. And when we're testing them, if we're testing them actively, that's fine. But if you're testing them passively, you have to be very careful, because their joints go past a normal range. So we don't want to take their joints past a normal range, even if they can go past that range. We want to keep them within a same range. Again, I'm saying normal, aren't I? We want to keep them within a safe range. They become much more prone to dislocations and joint laxity and lack of stability in the joint. The wrist, very simple, bend your wrist down, pull it back up, so that's flexion and extension. This lovely movement, imagine you're waving, I'm the queen, well, not anymore sadly, but I'm royalty, I'm waving out of the royal carriage. Ulnar deviation, that picture on the right is ulnar deviation, so this one on the left, this is radial deviation. Can you do those movements? And this is the movement I was telling that's very important. While you're sitting, if you turn your palms to face the ceiling, you've done supination. And if you turn your palms to face the floor, that's called pronation. So supination, turning them up, pronation is turning them down. And that occurs at the elbow joint as well as the wrist. And I want to tell you a little story in a minute. Wrist extension may be very important, part of exercise, but this lady, I'm just using it, this lady exercising as a demonstration. Many people, they have to push themselves up from the floor if they're manual workers and they're having to, I don't know, you might be getting into a carpet or under, to fix as a mechanic. Under a floor, the pit of a car, rather, a vehicle. You might be having to push up from the ground if your work's, below level, all sorts of things. You might have to push a trolley, if you're working for a company that's got warehousing. So pushing through an extended wrist is a very common need. I damaged my wrist, not knowing it, by using a very heavy wheelie trolley. That's not me, by the way. That's a stock photo I was able to use. I used to carry lots of heavy equipment in a very heavy kit. A lot of it, because I teach anatomy. And I actually damaged my wrist because I always used my right wrist, and I pulled the trolley behind me. And one day when I was testing someone, I was doing a strength test, it actually hurt my own wrist. I thought, why is that hurting? I was testing supination, so turning the palm up and turning the palm down. And what it was I'd actually developed a weakness, because if you think about this, if you put your arm behind you, so imagine you've got your arm behind you and you're gripping a trolley, you're always in pronation, but all the time, as you're going up and down curbs, you're doing slight adjustments with your wrist as you're pulling that trolley. So all the time I had a very heavy weight and my wrist was in pronation, and I was forcibly controlling it with small movements of supination and pronation. Fingers, very interesting. We can do flexion, so bending your fingers, curling them in, extension, opening them up. This is an image of someone who's got the fingers in sort of almost a neutral position, but some people call that extension, but they're neutral. True extension is if you put your hand on a desk, for example, and then you try and lift your fingers off the desk, that's extension. But they're also abducted. Can you see? So they're taken apart, and the opposite of that is adduction, bringing them in together. If you make a fist, you're in flexion, and what you need to ask yourself is, what degree of finger flexion or gripping is important to that person's role? So, for example, to push a trolley, do you need to grip with force? Is it okay to be able to just grip with a few fingers? What if someone's missing some fingers? Could they still do that job? What sort of modifications might need you to put in place if they had some fingers missing, if they had an accident or something? Do they need to use their thumb to grip? What if you were using a stick or a walking aid? Do you need to be able to grip it? How do you need to be able to grip it? So the degree of range can be very significant. And as we know, some of the modifications we might put in place could be something like putting a great big, have you seen those things they put round what they call, scaffolding, these lovely bits of foam. Whenever I see them, I always pick them up and steal them if they on the floor. Those big bits of foam, because they're great for people who've got grip problems, because you could put it, if you could find a way to safely attach it to the handle of a stick, that could be useful. But if someone's job was to push something and they couldn't do a narrow grip, as long as they've got enough strength, maybe adding that large piece of foam could be like really helpful. I mean, we often add it to things like tennis rackets. So if someone wants to play tennis, I know that's not occupational health, but if you want to play tennis and you have some problems, sometimes we would suggest putting a big piece of foam on the racket, because then it alters your grip. Opposition is a movement of the fingers and thumbs. It's a very specific movement. I've asked you here a question. Can you think of an occupation where that's important? Now, if someone was a sewer, they were a machinist and they have to thread needles through a machine, that's important, isn't it? If their job involved that very fine dexterous movement, that's very important. If you were dealing with a surgeon or an optician or someone who has to manipulate fine objects, that's very important. But it's also important for people who've got to pick up small things, tiny little things like screws or nuts or bolts. That's important, isn't it, for people's roles? And again, just coming to the end here, I'm nearly finished. I know we're getting close to the end of time, but I am nearly finished. I just want to tell you that I did have someone, and their job was a phlebotomist. And what was interesting was their role as a phlebotomy, they could do most of their role, but they couldn't actually cut the packets where they had to open the phlebotomy packets where some of the sterile equipment came in, and we were working with them to develop this dexterity, because they just physically couldn't do that particular movement, and they couldn't do certain fine movements, and so it had to have a very modified role temporarily, because obviously that's involving other people, involves needles and things, very specific and skilled role. You've got to be very careful with that, obviously, so it could really impact on someone's job. But in a lot of jobs, that fine opposition movement may not be needed. The knee, again, you could do a goniometric measurement. You could measure the degree of flexion, but think about function. Can that person squat down? Squatting involves full knee flexion. That lady is a good example of full hip flexion and full knee flexion on the right knee and almost full knee flexion on the left knee. It also involves a lot of movements in the ankle joint. So to ask someone to squat is a very good, quick way to do a full assessment of the lower limb. Can they squat down? Is there any impairment? And of course, it tests strength and it tests balance. I've put a question about knee rotation because knees can actually rotate, and that is another example of an accessory movement. So a person, their knees all the time are doing a minor degree of rotation without them knowing, but they personally can't choose to test their knee rotation. So in summary, the assessing range of motion, it helps us to determine if there's a limitation in the joint. It helps us to identify different musculoskeletal conditions, and it helps us to attest to determine function. I've got just 1 minute over, so I'm sorry about that. Hopefully, if you've got any questions, you can quickly ask them, and I've left you a little quiz here as part of the slides if you do want to re-watch that. So I'll just go back to the beginning. Thank you for listening. Any questions? Have we got time for any?
Yep, we've certainly got time for a few questions. If people want to hang around and ask you anything, Jane, that would be lovely.
I shall sip my cup of tea, my cold tea, while you're thinking of a question.
Could I ask you a question, please?
Yes, far away, do.
Somebody with hypermobility, a young person, and they're doing working where they're doing kind of active range of motion, and they're lifting up to about maybe 20 kilograms in weight repetitively. Is there any restrictions that should be put in place, or any recommendations for somebody like that?
That's a good question. So lifting up to 20 kilograms in weight, they're young,
Yeah,
and it's repetitive.
they've had a few dislocations before.
Yeah, there's quite a lot of risk factors there, aren't there?
Yeah.
I don't know of any specific guidance about that, but I think the last SOM, there's a very good paper that came out by SOM. You mentioned at the beginning of the webinar that there's going to be an iOH and SOM conjoined joint webinar presentation. They've got a very interesting document about helping young people get into work and thinking about musculoskeletal conditions. So that's worth having a look at. I think that's freely available. And what I would say is, what assistive equipment, is there any assistive equipment that they could use to help them? Is there any way that they, for example, to avoid the degree of movement that they're doing, that they could maybe elevate themselves so they're not lifting it through as great a range? Could what they're lifting it onto be lowered? Maybe that's an option. It might not be an option. Can they break up that repetitiveness, or could they break up the load that they're actually lifting? Now, it may not be possible, but those are definite risk factors, aren't they? And especially if they've had a history of potential dislocations or problems in the past. Yeah.
Yeah, so it would be kind of considered a restriction then, for like not something that you would recommend that they should be doing. I mean,
well,
if you're lifting smaller weights, or like,
yes,
does that make
lighter
any
weights
difference?
would be, yes, it would absolutely make a difference. So lighter weights would be a different. You definitely want to, if they've got an option, to be referred for strengthening, because there's lots of strengthening specific to the joint that could be done. They might want to have an assessment of their workplace to see how are they doing it. People fall into bad habits. They might have had manual handling training and then they fall into bad habits. So that's going to be really important as well, isn't it?
Yeah, I often think, like with manual handling, it looks ideal when you see it on paper, but it never works that way. Sure, it doesn't. It's.
Yeah, and there is a lot of research around whether it works or not, and a lot of it is about there's some very interesting research about that. The ACPO, Association of Chartered Physios and Occupational Health, they do some special training on that.
Okay, thanks for your help. Thanks.
You're welcome. Thank you.
There is a variety of courses that would be available to nurses, particularly about doing workstation assessments, particularly with ergonomics. I start an ergonomics module at the University of Derby in January, which teaches practitioners to use a variety of tools, including the HSE assessment tools, and also the ruler and Reba. So they would be
really a great suggestion. Yeah,
absolutely. I mean, we get all of the occupational health specialist community public health nurses do it. In fact, I can see that we've got a couple that have done it recently, and it's a really good little module to do as well. So that starts in January. It's £1,100 for one module, which is 20 credits at either level 6 or level 7, depending on which way you want to do it. Okay. Right. Any other questions for Jane? Right. Okay. I am going to stop recording. Okay. But thank you very much, Jane. That is absolutely
my pleasure.
So our hearty thanks, and also congratulations again on gaining your PhD.
Thank you.
Right, so
Thanks
if I
very
could
much.
just